Hosting our Optometric Glaucoma Foundation Educators Meeting. This is our 4th annual meeting that we've been doing the past several years. For many of you, you may know that we typically rotate this meeting between 3 sites, SUNY Optometry in New York and ICO in Chicago and Berkeley College of Optometry in California. This year, obviously, things are different. So we are bringing to you a virtual meeting. The OGF and the OGS have always partnered together to bring educational content to the optometric glaucoma educators. That's one of our main missions here. Of course, on the meeting today, we've opened this up to many OGS members, residents of optometry across the country, other faculty at the schools and colleges of optometry across the country. We have 175 registered people today, so that's really wonderful. I thank everyone for joining today. I'm really pleased to help introduce our 3 speakers, Don Hood, Tom Freddo, and Peter Lally, who have really worked tirelessly to put together this virtual program for the care and management of our glaucoma patients, and we really look forward to their presentations today. To that end, I want to remind everyone that it's best if we use the Q&A function in your Zoom panel to get questions to our speakers. With the number of people that we will have joining, audio questions aren't really feasible or possible at this time. So put your questions in there. We will have a moderator for each of the sessions. If you don't remember what our lineup is for the agenda today, I guess I can't share my panel, but Don Hood is going to do the first 2 hours here. Murray will do his introduction in a minute or two. Tom Freddo is then doing 3 hours in the middle on anterior segment, histology and anatomy. And then Peter Lally is coming on later in the day to talk about examining the optic nerve head in glaucoma. So we have a really, very comprehensive program. Again, the goal is to get this information to our students, residents, clinical faculty who are teaching glaucoma at the university and college programs of optometry across the country. We certainly welcome all the OGS members who are participating here. And I thank you for all the work. I thank Murray for putting the program together. I'd like to thank Kelly Rogers, of course, who is our executive director and always works tirelessly to make Zoom work for us and get all our registration done and everything like that. So appreciate everyone's work and efforts there. It's really unfortunate that we are not having a live OGS meeting tied into the Academy this year. And that's part of the reason and rationale for why we wanted to have this virtual educators meeting here and test the waters. And we thought this was the right time frame, the right speakers, the right content. And certainly by the number of registered people, we think we've hit it right on the head and getting this correctly. So we'll look forward to being back in 2021 with, I presume, live meetings at some point. We'll see. But thank you again, everyone. So let me turn it over to Murray to do introductions for our first speaker. And I'll be back with you later during the day to move things along during our program. Thanks, everyone.
Great. Thank you, Michael. Welcome, everybody. I hope you enjoy this program. I put the program together, and the concept of this program is that it was originally when I put it together, it was the idea that we have an educators meeting as well as our regular OGS meeting. And as Michael stated, the intent of the educators meeting was to create a program for educators, and that's why we have Don Hood and Tom Freddo and Peter Lally. Tom will be talking about anatomy, histology. Peter will be getting back to looking at the optic nerve, and Don is a refresher, as he was the original speaker for us for our the first time we did an educators meeting. That was 3 years ago at SUNY in Manhattan. And I still remember calling Don up and saying, Don, you know, would you be able to and willing to speak at our first educators meeting? And he said, fine. And I said, well, let me explain what I have in mind. And you know what I said was, I wanted 7 hours. I wanted everything that you could say about about how you look at the OCT. I want you to convey that. And he thought I was crazy. But somehow I convinced him, and he did that one day, and it was incredible. And those particular sessions, Don did record and put on his website, on his lab website. And this is a refresher now, a couple of years later, looking back at this material and other material. You know, Don is the James F. Bender Professor of Psychology and Professor of Ophthalmic Science and has been a member of the Columbia University faculty since 1979, where he has won all 3 of its major teaching awards. He holds a Master's of Science, PhD degrees from Brown University, and honorary degrees from Smith College, Brown, and SUNY College of Optometry. He's an elected fellow of the Academy of Arts and Sciences and a recipient of the Alcon Research Institute Award. Don currently serves as editor-in-chief of IOVS, and he's also on the editorial boards of Documenta Ophthalmologica and Journal of Glaucoma. He has over 300 publications dealing with neuroscience of vision, and much of his work is concerned over the last 30 years on diseases of the retina and optic nerve. And he's had continuous grant support from the NIH, NEI for over 45 years. So with that, let me introduce Dr. Hood. Don.
So I share my screen now, right?
Yep, perfect.
The host has to disable, something has to be done at your end here.
I can hear you, Don.
No, I know, but you don't see my screen though, do you?
No.
Yeah, so when I hit, you have to enable me to do it.
Okay.
Host disabled attendees.
Now you are. I think now you can.
Okay. Yes. You see it now? Are we set? Hello?
We're good.
Yes.
Don,
We're good.
Oh,
We're
you
We're
are?
good.
Okay.
Sorry, Don.
And
Yes,
you can
sir,
hear
you're
me?
good.
Yep.
Okay,
If you go full screen. Perfect.
okay. All right, yeah, so thank you, Murray and Michael for inviting me. And it is true that Murray talked me into giving 7 hours of lectures. Still can't believe it. Before I start, let me just give you the obligatory financial disclosures. I have grants and equipment from both Heidelberg and Topcon, and it's definitely relevant to my talks. So I'm going to split the talk today, the 2 hours or so, into 2 parts. The first part is slightly shorter than the second part. And in the first part, I'm going to deal with what can OCT teach us about the nature of glaucoma. Let's see if I can get the faces out of the way here. Okay. And then in the second part, I'll talk about what are the implications for the clinician and where you can find this information on your machine. Okay, just so that we are using the same terms, let me define some terms here and go over the anatomy at the same time. So I'm still having trouble finding some place to put these faces here. Oh, well. I guess nothing I can do about that. Okay, so the retina's a little piece of the brain at the back of the eye here. So this is an electron micrograph of a human tissue. And you can see the 3 layers of cells, the receptors, the rods and cones, the bipolar cells, and then the ganglion cells, which are the star of the show today. Light comes in this direction, of course, absorbed out here in the outer retina, and then the electrochemical activity is communicated this way, where the receptors synapse with the bipolars. They synapse with the ganglion cells, and it's the axons of the ganglion cells that leave the retina as part of the optic nerve. And you've got about 1 million ganglion cells and 1 million optic nerve fibers. All right, so receptors in the nuclear layer, and then the layers that we're going to be talking about today, the interplexiform layer, which contains the dendrites of the ganglion cells, the retinal ganglion cell layer, and then the retinal nerve fiber layer that has some glial cells and some blood vessels, but largely contains the axons of the ganglion cells. Now, since glaucoma kills retinal ganglion cells and their axons, right, the layers that are going to be affected are the interplexiform layer, the retinal ganglion cell layer, and the retinal nerve fiber layer. So these are the layers here that are damaged layers. This layer is often combined, and when I talk about ganglion cells in my talk today, I will mean the combined layers, and sometimes that's called ganglion cell, retinal ganglion cell plus, sometimes it's called GCIPL. Okay, the other piece of anatomy that's absolutely essential that you review is how the axons travel along the retina as they cross the eye from the cell bodies to the disc. And you've all had to memorize schematics like this for different exams. This schematic is meant to capture the following facts. Ganglion cells on the disc side or nasal side of the fovea send their axons more or less into the optic disc. During development, the axons from the ganglion cells on the temporal or the side away from the disc arc around and avoid the fovea. They bunch up down here, and this region where they bunch up is a region that's particularly vulnerable to glaucomatous damage. And the same thing is true up here. Here's an eye that was born with some of the axons myelinated. As you probably remember, your axons are unmyelinated until they pass the lamina cribrosa in the disc. And you can see nicely in this the arcuate nature. Okay, this is key. Because of this anatomy, and because glaucoma acts largely at and in the optic disc, damage due to glaucoma has this characteristic arcuate shape. Same thing up here. All right, so as you all know, there's no litmus test for glaucoma. So glaucoma is traditionally defined as a progressive optic neuropathy. That is, it's a disease of the optic nerve that progresses, and is characterized by a particular pattern of anatomical and behavioral changes. And by anatomical, we used to mean simply the appearance of the disc, like in disc photos. Now we're increasingly taking in consideration OCT information. And by behavioral changes, we mean visual fields, and I'll come back to that. All right, so this talk is about the OCT and about the particular pattern of damage that is typical of glaucoma. So again, these arcuate shaped defects. So remember, we're going to be looking for patterns characteristic of glaucoma. All right, so next part, what can you actually see in the OCT scans? I want to try to convince you that there's an incredible amount of information in these scans that at the moment, many glaucoma specialists are ignoring. So I don't think I have to remind people here that you can sort of think of this is ultrasound, but with light. And because light has a shorter wavelength, the resolution here is much better than you would get with ultrasound. So here's a line scan of an OCT through the back of my eye. And if we colored in one ganglion cell, the ganglion cell would look like that. And the axon from the ganglion cell would travel like this and go into the optic nerve. So this is the retinal ganglion cell plus the interplexiform layer. This is the retinal nerve fiber layer. Now, it was traditional, based on the early versions of the OCT, for glaucoma specialists to look at scans that were circumpapillary, that is, they were circular in nature around the optic disc. And here is what one of those would look like. So when I show you these scans, these so-called circular scans, what you want to think of is that this is the retinal nerve fiber layer, all right? And it's as if you're looking in this way, right, like this, at this circle, but then we've flattened the circle out. That is, you're looking in right in there. All right, now, over 10 years ago, with the original Zeiss time domain machine, there was really only one machine that was being used in the clinic, and we all looked at the same report if we were interested in glaucoma. We all looked at this circumpapillary retinal nerve fibrillary report. And this report sort of set the paradigm for subsequent reports, both for better and for worse in a couple of cases. It involved an average circle scan because at that time, the machines were relatively slow and you only had enough time to get a circle scan. And the image here is presented very small because at that point, the image did not have particularly good resolution. In fact, if you actually looked at this image at that time, you might not have believed the reports. And in fact, this report changed the way we approach glaucoma. You know, this even with this poor resolution, this was a major advance forward. This was called a T-SNP curve by some because it scanned from temporal to superior to nasal to inferior to temporal, that is T-SNP. All right, with newer reports, and I want to emphasize, when I say newer, I mean the last 8 years or more. For the last 8 years or more, this has been the quality of scan that you're capable of getting from your machine, right? The images are much better than the time domain machine. This is spectral domain, right? This is pseudo, of course. So in this case, retinal nerve fiber layer is more reflective, and you're seeing this hyperdense region. This curve, as you probably know, is the thickness between these two green lines, and these green lines are the segmentation lines that the software puts as it tries to delineate the retinal nerve fiber layer. All right, so let's take a look at this. So here's a fundus picture, and you can clearly see that there are nerve fiber defects here. In fact, there's only this region here that looks healthy. What does the OCT look like that corresponds to that? Well, here it is. And now this retinal, there's the retinal nerve fiber layer. That's what the normal looks like. That's normal. This is all abnormal, right? What you're looking at here actually is the temporal half of this scan. You're looking at this much here because I plotted this as if it was scanned from nasal around. So this is what I'm going to call an Einstein curve. So in the Einstein curve, it has the temporal region in the center of the disc. So now we can relate this to this. So let's take this. So this here corresponds to this here. So let's flip it. So you can see what you're looking at. You know, this corresponds to that, that corresponds to that. So this tissue here, this retinal nerve fiber layer that's maintained corresponds to this on your fundus picture. So this would be a preserved ganglion cell with its axon, for example. We can take this and flip it the other way, which might help you. So I hope that helps you not only see the detail here, but also see how it's related to the anatomy. Okay, so what can we see on the OCT? So a couple of years ago, we decided that if we wanted to understand better what we were seeing on the OCT image, it would be useful to do a study in which we look at adaptive optics SLO. So I'm not going to go into adaptive optics, but suffice it to say that it's a way to, using mirrors instead of glass as a lens, to get rid of the aberration. So it comes from out of the astrophysicists' desire to have sharper images of distant galaxies, for example. So anyway, we teamed up with Alf Dubra and Rosen, Richard Rosen and Toko Chu. Alf had built the state-of-the-art AO-SLO for Richard Rosen. Chu was a postdoc who's now a faculty member who was in charge of running it as well as interpreting it. So here's an image that she did on one of our patients. It's made up of a whole bunch of little AO-SLO. It took about 45 minutes to do this. And it took us about 2 days of an undergraduate lining everything up and adjusting it and so on. And what we want to do is compare it to an OCT. Now, this, of course, took about 2 seconds to obtain and maybe 10 seconds to analyze. Now, we can line this up because this scan was taken about in this position here. And we know where we are because these vessels create shadows. So that vessel is there, that vessel is there, and so on. So I want you to notice that this is abnormal. There are no retinal nerve fiber bundles, whereas these white lines are bundles of axons or retinal nerve fibers, right? So wherever you see some remaining bundles, you see some retinal nerve fiber layer on the OCT. This is pretty normal looking, and that's pretty normal looking. That's just a little bit left and a little bit left. And then these other regions here in orange are totally wiped out. You know, they're gone. So what struck us is that these little tiny things that you might think are artifacts, these little tiny hyperreflective regions, they're actually preserved retinal nerve fiber bundles. So the message for me at that point is we're not making optimal clinical use of the information in the OCT by just looking at summary statistics. All right, so what are the lessons that we've learned over the last couple of years from the OCT about glaucoma? I want to first consider where the actual damage is on the disc. And I'm going to use data from this study that we published in 2012. And we had cube scans, OCT cube scans, centered on both the macula here and the disc. And from the macula scan, we were able to get retinal nerve fiber layer thickness and retinal ganglion cell thickness. And from these scans, we were able to get retinal nerve fiber layer thickness. All right, so let's look at this first. So here's a pseudo color plot where red's going to mean very, very thick and blue is going to mean very thin. All right, so in this paper here, what we did is we took a group of normals and we took a age matched group that would be matched to the patients we had, and we averaged their cube scan data. So again, this is thinner retinal nerve fiber layer, that's thick retinal nerve fiber layer. So if we put this on top of a fundus picture, you can see where the main thick arcuates are of axons. All right. Now I want to remind you that we've known for years, since the work of Quigley and others, that the superior and inferior quadrants are the most vulnerable regions to glaucomatous damage. So we then took a group of moderate glaucomas. So these were early and moderate, but not advanced. And we averaged them. And then we subtracted this from this. And I'm going to have to apologize now because red means something different, but this is a convention in the field. Since we're subtracting these two, green now means not thinner than normal, and red means much thinner than normal. So red over here is good because it's thick. Red here, just as in probability plots, are bad because it's very thin. All right, so let's blow this up. Within normal limits, extensive thinning. Extensive thinning. So let's put this on top here. And so you can see that most of the damage here is in the temporal half of this of the superior quadrant, and almost of the loss at least, and the inferior half of the and the superior half of the inferior quadrant. So what's new here? Well, not much. Well, but what's new is it's not the entire quadrant here that's particularly vulnerable. It's the temporal half. Not much new, but hang on. Okay, so that's where most of the damage is. Okay, so that's for the disc. Now, what about the macula or central retina? All right, so again, just give me 1 second because I'm still trying to figure out how I can get rid of this. Ah, got it. Sorry. All right, so in addition to the information about the disc, we also had macula scans where we had retinal ganglion cell thickness. Here's what it looks like for a group of average normals. Again, dark red is thick, dark blue is thin. You can see the donut of ganglion cells around the healthy fovea. This circle, which I'm going to refer to as the macula, I'm going to call the macula plus or minus 8 degrees. Different specialists define macula in different ways. The anatomist and the physiologist tends to talk about where the ganglion cells are the thickest. I'm going to use that. So plus or minus 8 degrees. The reason why that's so important is that's only about 2% of your retina area, but it has over 30% of the ganglion cells. And it's the region that's so essential for you to be able to read, see your children or grandchildren, drive, etc. All right. So now let's replace let's look at this for the macula and ganglion cells. So we're going to replace this this here with ganglion cells. That's for the patients. That's the difference between the two. Here's a blow up of that picture. And remember, this means more damage. So this means extensive damage. And this is within normal limits. So now we've learned something. We've learned that early and moderate glaucoma has a huge effect on the macula. So this is ganglion cell loss, retinal nerve fiber layer loss, plus or minus 8 degrees, right? Okay, so early damage includes the macula. So here's our model. We actually published this first explanation in 2011, and it provides an anatomical explanation for why the traditional view that the macula is not affected early in glaucoma is wrong. So that's plus or minus 8 degrees. Remember, this is the region of damage, right? All of these, this area here, the ganglion cells go to the temporal region, which as the traditional model says, is relatively not vulnerable, less vulnerable. However, these ganglion cells here go right into the most vulnerable part of the disc. And we call this the macular vulnerability zone. So we go back over here, right? This is the temporal quadrant, but these axons are going not into the temporal quadrant, but into the inferior quadrant and into the inferior vulnerability zone. So why does early damage include the macula? Well, actually, there are two reasons. We've documented in this case the fact that the local defects often include the macular vulnerability zone, but we've also documented in subsequent papers that there's also an early diffuse component to glaucoma in general, and that includes the macula. And we now know, because of the work of Dana Blumberg at Columbia, working with a number of colleagues at Columbia, that it's this diffuse damage that can affect face perception and various other complaints, vague complaints that you often get in early glaucoma. Okay, so how common is macular damage? What's the documentation? So here's the first study we did. We've done a number of these studies now, but we took 57 eyes we had with early glaucoma only because the mean deviation was better than -6. Right? And we found that over 3/4 of them had damage that included the macular vulnerability zone, and 88% of them had damage that included the macular region widely defined. And essentially all of the eyes had damage that included either this or this. Right? And here's a bunch of references from other anything in yellow are our studies, the ones in white are from other groups around the world. Okay, so to summarize, I want to create what I call the traditional or implicit model of early damage that certainly was held by most 5 years ago and by too many still today. So the traditional view is that the superior and inferior quadrants are the most vulnerable. The temporal is relatively less vulnerable. So that's the traditional assumption. Is that true? Yes, by and large it's true, except we just have that minor footnote that actually it's the temporal half that are the most vulnerable. Second, it's often assumed, it's traditionally assumed that the temporal quadrant is less vulnerable. And yes, to a first approximation, it is true that this is the most vulnerable region, followed by this, followed by this. But early damage can include diffuse temporal damage. Third assumption of the traditional model is that the axons from the ganglion cells in the macular region of the retina enter the temporal quadrant. The answer is no, that's not entirely true. All of these are entering in the most vulnerable inferior vulnerability zone. And then, therefore, according to the traditional model, macular function is minimally affected in early glaucoma. No, no, no. Arcuate defects are present in the earliest stage of glaucoma in the macular vulnerability zone, and as is early diffuse damage. Okay. Third, how do we categorize early glaucomatous damage based on the OCT? So in this paper, a review paper here, I posed the following hypothetical situation. So assume the OCT came before the visual field and automated perimetry. Suppose you didn't know about automated perimetry. Maybe you knew about Goldman perimetry, but you didn't know about automated perimetry. And all of a sudden OCT came along. How would you have categorized visual field defects? I'm going to claim that you probably would look at it the way a radiologist would look at MRI or CAT scans. That is one thing you notice if you look at this scan here. So we're going to focus on this part of the scan here, which is, this is an instant plot. So this is the central part or the temporal half of the disc here, like so. Okay, so the first thing you'd notice is that this defect here is relatively local. So one thing you might note is where it's occurring. So it's going to have a different effect on your vision if it occurs here versus here versus here. There's also local damage in this eye over here. Then here it is. The second thing you might notice is that it varies in severity or depth. So if I blow this up here, I get this, the retinal nerve fibrillation is almost gone, not quite, right? In this case, it's not as affected. It's in the same location. It's going to have an impact on vision, right? So that versus this, this is a bigger loss than that. And then width. So here's a third eye. Again, damage is in the same location, but it's a much wider damage. So here the damage is extending from here to here. And then the third is local variation in depth. So you'll notice that here it's missing. Here you have a little bit, and here you have more. So it's abnormal in this whole region, but to different degrees. And there are corresponding, thicknesses down here. So how would we categorize the pattern of glaucomatous damage? Well, it can vary in any one of these dimensions. And this last one here is what I emphasized when I looked at this, that there was a lot of local variation that we can see on the OCT. So what are the implications, right? Well, one implication is, I'm going to bring out one implication by just looking at this one part of the scan. Let's just take this one part of the scan, right? Because I'll show you in a moment, this pretty much covers the upper visual association with the defects in the upper visual field. So this region can vary in any one of these different ways. And we're talking about this much of the scan. That's your inferior vulnerability zone. That's the macular vulnerability zone. And here are 5 different eyes that have various different degrees of location depth, width, and local variation. So the message here is we're going to get a wide variation of OCT damage or anatomical damage. All right, so now how do we relate this to the visual field defects? Well, here's a categorization that you probably had to learn as part of, since many of you teach, you may still be teaching it. This is the Keltner, Johnson et al. Classification that's so common. Before I do that, let me just back up and review something about visual fields. Two things about visual fields. First, this is the reason why they're so important, of course, is because not only is it a behavioral measure, but because there's no litmus test, we're looking for agreement between anatomy and behavior, right? The most common report, so the second thing I want to do is remind you of the reports that are used. The most common report that's used is the 24-2 pattern or 30-2 pattern. It's the same pattern, just how wide it is, right? Now, I want to remind you, the way this is obtained is patient looks in here and presses a button whenever they see a light, and the lights are relatively brief and relatively small, right? So there's the grid here is relatively coarse. These dots are these locations are spaced 6 degrees apart, starting up and over at 3 degrees. What this means, since the macula is plus or minus 8 degrees, you only have at most 4 points within that very important macular region. These numbers, let me remind you what they refer to. They refer to the relation. They refer to the sensitivity, loss in sensitivity of the individual to normative controls. So, for example, minus 13 dB here means that this patient at this point was 1.3 log units less sensitive than age-matched controls, or needed about 20 times more light. If this was a 0, it would mean that they needed the same amount of light as age-matched controls. And then I'm going to also be showing you these probability maps where the symbols code the probability of significance. And I think the only statistic I'll make use of is the mean deviation here. You can think of that as a average of these points. All right, this is the most common visual field test used to diagnose glaucoma. All right, so how do we compare this to the OCT? Well, first of all of these examples, I've modified their examples a little bit, so they're all upper visual fields. So this is what they call the nasal step. This is a paracentral defect, partial arcuate, altitudinal. So how do we relate this local damage to visual field locations? Well, here's a model that you need a map. Here's a model that relates the area on the retina and the disc to the location of these points, right, for an average eye. These are actually 30-2, so to get a 24-2, just make believe the outer ring is missing. All right, now, what I want to emphasize here is all of these defects here are due to damage in this region here and this region here. And here's the model on top of it. And even up here, most of this is also due to this. This damage up above here would be, you just have to extend this a little bit. So all of these visual fields that you're used to seeing are due to damage in this region right here, right? And in fact, most of them are due to damage in this relatively small 45-degree region. Produce all of these different fields and all the fields that you see, right? This region right here. Okay, now remember this, I'm gonna relate this back to this. So all of these field defects are due to variations in this region right here. Okay, so the message here is we should expect a wide range of patterns of visual field loss. So let's go back to these examples, right? These are all in the same area. Here are the visual fields for these 5 individuals. And as you might expect, there's going to be a wide variation. There aren't going to be simple categories. And that's the model, right? And the damage includes the macula in almost all cases. Okay, so what are so we're going to turn in the next talk to the implications for the clinicians, just as a, let's see what I have, just as a preview. What I'm going to do is I'm going to start out with what I'm going to claim is a common set of clinical tests, which is the 24-2 visual field and the OCT disc scan. And because of these findings here, I'm going to argue that since the 24-2 points poorly sample the macula, and there are a large number of studies now that agree with us. So in terms of clinical suggestions, for starters, what Gus Demores, who's my partner in this, and I have been claiming is if there's a reason to do a visual field, there's a reason to do a 10-2 at some point, as well as your 24-2. If there's a reason to do an OCT, you must include an OCT, a cube scan of the macula, not just a cube scan of the disc. Okay, so I think, Murray, I think it's now time for questions.
Okay, so if anybody has any questions, feel free to, and here is one. Can you ever have damage appear on the macula scan before the retinal nerve fiber layer scan?
Yes.
So it is possible.
The answer is absolutely. And you know, it's if you think about do I still have the screen?
Yes.
Yeah. So if you think about it, if you have local damage that's over here someplace, it's going to show up better on 10-2s than on macula scans. But you know, this is fixation. Right, and then the macula goes to here someplace.
Okay, so can you pick that up though? I understand that you can pick it up with a 10-2, but how about the common, you know, whether it's the, you know, the serous ganglion cell scan or the OptiView or the TopCon? Do you see those on scans, or do you see them by looking at, you know, what I mean by, you know, by looking at looking at any of the OCT printouts, or is it something that you need to look at the scan, or?
No, yes, I'm going to show a number of examples in the second part.
Okay, so you will get to that. Okay.
Yeah, and the answer is you want to look at probability. You want to look at the probability maps, so the so-called probability or deviation maps that are standard.
Okay. And there's another question, Don. What is your opinion on the 24-2C Humphrey visual field, the new pattern?
Yeah, I get that a lot. The answer is the jury's still out, because there's some nice studies going on at the moment, so we really have to see. But the answer is almost guaranteed. We know that the 24-2, based on that alone, you can often guess what there's macular damage, but often you'll miss it. And we know with the 10-2, you'll pick up the macular damage. It's not going to surprise anyone that when you're using a smaller subset of points, you're going to be somewhere in between that. You know, so I can predict with confidence it's not going to be as good as doing a 10-2, and it's going to be better than just doing a 24-2. And where we are in that continuum, we'll see.
Which probably is in large part, you know, what Zeiss, you know, at the beginning thought it would happen. Can you comment on the potential use of the newer 24-2C with CETA faster? Any idea?
Well, that's what we're just talking about, right?
But also they were asking more about CETA faster.
Oh, I see. The answer is no, I can't.
Okay. And again, I would say that also is, there are a few studies that have come out on that. One by Jack Few and the Australian group, that was published and had a print, I believe, in AJO. But I think we'll learn more. Next question, Don. I've seen some older patients, 75 years and older, with damaged GCC loss, but nerve fiber layer relatively good. Is this due to the natural age-related loss of the GCC that is perhaps outside the normal database of the OCT?
Can you give me the beginning part of that again? I missed it.
Older patients with what appears to be GCC loss, but the nerve fiber layer is good.
Okay, yeah, I got it. I'm going to make a prediction. I'm going to predict what they're talking about is not arcuate appearing, but an overall red appearance.
Exactly. Yes.
On that panomap. I think those normals are really good normals. You know,
We talked about that before.
yeah, I think that panomap, which I'm going to talk about, I like the panomap. I think it is. There's going to be a tendency to pick up some diffuse redness, you know, that I think might be normal, you know. And I think we'll talk about this in the second part. The hardest thing to pick up is subtle diffuse damage to the macula. And I like to see three things. I like to see the ganglion cells down. I like to see the retinal nerve fiber layer borderline or abnormal in the temporal region. And I like to see a 10-2. You know, if I have all three, I'm comfortable. If I have two and a patient that has vague complaints about trouble with light and dark or glare and so on, I'd throw that in too. So if I add that as a fourth, I want to see at least three of those things.
Okay, thanks. Couple more. And can I ask everybody that when you ask questions, use the Q&A. Do not use the chat button because there are a few that came into the chat, but we're going to miss them. Please use the Q&A. Since glaucoma patients are often older, the macular scan is often affected by non-glaucomatous pathology such as macular degeneration. Can you differentiate damage from, how do you differentiate damage from the various causes?
We're going to talk about that.
Okay, so we'll leave that. What is the anatomic?
Make sure you come back to that because, you know, make sure I get all aspects of it. Yeah.
Okay, so if we don't get to it, Carl.
We're going to get to that topic in a big way, but the individual asking it may have a particular thing in mind. But
what is the anatomic explanation for seeing macular damage prior to circumpapillary nerve fiber layer damage if the damage is occurring at the lamina?
Oh, okay, yeah. So that's a great question. And in fact,
that's a good question.
You really have to be careful when you say I want to distinguish between detecting damage and whether damage exists, right? So the person's absolutely correct. I'm not deviating from a model where the damage is largely at or in the disc. However, you damage axons at that point, and now you get retinal nerve fiber layer change and you get ganglion cell change. Both are changing. Now we ask, which can we detect first? And since the ganglion cells are so thick right around fixation, right? It's easier to detect the change there than it is someplace else. So for example, anyway, let me just leave it at that. So, yeah. So it's a matter of the standard deviation or the variation of your measure, not which comes first.
That's a great explanation for that. Can you explain the nerve fiber layer loss pattern in a complete arcuate defect versus an early nasal step? And I believe you already discussed.
Oh, we're going to talk about. I'm going to show you some nice exampple of that.
Okay, so let's hold that.
So let me just give the punchline now in case I forget it later. When I see nasal steps, I don't think early glaucoma. I think there's already macular damage, because the distance between on the disc for nasal step versus macular damage is only 40 degrees or so. And damage is not that local. So right. If you see a nasal step, there's damn good chance you already have macular damage.
Okay. It seems that the ganglion cell layer is extremely thin and high myopia. Is there a reason why?
Oh, that's also controversial. Yeah, it's the answer I think is partially developmental, you know, due to the myopia, and partially just due to the it's spreading everything out. I mean, I'm probably the wrong person to be answering this.
Right. Two more
I think it's a
questions.
combination.
Yeah, and then where in the macula would it be most vulnerable? I believe you talked about that being.
Yeah, so on a retina basis, it's the inferior region, and on a field basis, it would be the superior visual field. And I'll point that out as we go along into the next part of the talk too.
Okay. Last question, and then Don, move it. Can you ever see visual field damage before structural damage?
Absolutely, absolutely. And in fact, I'll mention this in passing, perhaps, but if I don't, the answer is we have a recent paper that says structure function is agreement is more common than thought. If you do 24-2 and 10-2s and you do macular and disc probability plots, 90+% of the eyes show good agreement. When they don't, you're just as likely to get structure before function as function before structure in terms of what shows up.
Okay. Okay, Don, so that's the questions for now. If you want to go to second part.
I will do that. Okay?
Yep.
All right, so same financial disclosures. So what are the implications for the clinician? So I'm going to start with what I look at, what I look for in an OCT glaucoma report. So this is from a publication in an issue of BJO in 2014. And the background, this is what we call our lab report. It's a report we've been using since about 2013. And the background's the following. I mean, we interpret OCTs for a number of different ophthalmologists. Largely, over the last 10 years or more, Jeff Odell comes to the lab every Wednesday afternoon, and we go over his patients as well as other neuro-ophthalmological patients from the tri-state area that are sent because Jeff is so good at what he does. And then we've been testing and interpreting, for example, Bob Rich's patients now for over 12 years or so. And Bob comes to the lab every 3 weeks or so, and we go over the more difficult cases. And in both cases, we're sort of acting like radiologists. We're interpreting it. And somewhere around 2013, after we had been doing this for a couple of years, a student, a very talented student of mine, Ali Raza, said, you know, we were shuffling paper, and then after we got done shuffling paper, we were shuffling PowerPoint slides, and you keep coming back to, and looking at the same ones. Isn't there some way to put it onto one page? So the challenge is we try to develop one page that would capture a lot of what we need. Not everything, but a lot of what we need. So let me tell you about the lab report, and then I'm going to tell you about commercial reports that share its characteristics. So one-page report for detecting glaucomatous damage. It's based upon, in this case, 2 cube scans. And these were a TopCon frequency domain, but it's the same kind of cube scans that you get with Zeiss, let's say. So one cube scan is centered on the disc, and one of its B scans would look like this. And from that B scan, we get retinal nerve fiber layer. And here's a thickness map for that. Red is thick, blue is thin. And then we have a cube scan centered on the fovea. And from that, we get both retinal ganglion cell, or retinal nerve fiber layer, and retinal ganglion cell thickness maps. And again, thick, thin. Yeah. So, key points. You need scans to cover both the macula and the disc. Today, with many machines, one scan will cover both. Other machines, you need to do 2 separate scans. And in both cases, you want to, in both the case of the retinal nerve fiber layer and the retinal ganglion cell, you want to extract the thickness data. All right. These thickness plots are then turned into probability plots, sometimes called deviation maps, by comparing them to healthy controls. So all the machines are doing something similar to this at the moment, where they take this thickness map, they compare it to healthy controls, and then color code it. So in our case, we have a continuous color code where dark red is 0.001, yellow would be 5%, green would be within normal limits or greater than 10%. So thickness plot, probability or deviation map, right? We're going to flip this along the horizontal line the same way the image in the back of your eye is flipped, because we're going to want to put this in field view to compare it to visual fields. So this defect here, right, shows up here as that abnormal spot. So now we can, for example, after displacing them correctly or morphing these points, we can put the points on, for example, for the 10-2. All right, so the third key point is you want both retinal nerve fiber layer and retinal ganglion cell probability maps. All right, so I said retinal nerve fiber layer 2. So the way we do the retinal nerve fiber layer is we turn this into a probability map, and we turn this into a probability map. They get stitched together, and actually the Zeiss machines and other machines do this automatically now, because this gets centered on the fovea, this gets centered on the disc, and this is in field view. Again, dark red, highly significant, green, not significant. So this is a retinal nerve fiber layer probability map. This is the retinal ganglion cell probability map. They're both in field view. It's absolutely essential that you understand what's plotted here for the rest of the talk. So send an urgent message if you don't understand this, and I'll go over it again. All right. We want to make it easy for the clinician to compare regions on visual fields in OCT. So since the 24-2 locations are plotted here, we can take the visual field and actually circle. In this case, we actually filled in the color, but you can just circle the ones that are abnormal. Here's a nasal step. Okay. And again, that's abnormal. This is not abnormal just for that. All right. Here's an illustration that the 24-2 can miss macular damage. This looks like a nasal step, but you've got a piece out of your ganglion cells here. All right. All right. 10-2 in this eye, right? You can see you probably would ignore this if by itself perhaps, but if we take those points and superimpose them on here, you can see you've got structure function agreement. And same thing here, structure function agreement. So that is the same location, and it's the same location as over here. So again, here's a 24-2, looks like an early nasal step, but it's also early macular damage. Now this assumes you can compare abnormal regions of visual fields in OCT, and this is the paper I was just telling you about. Structure function agreement is better than commonly thought in eyes with early glaucoma. So take a look at this paper and you'll see what I'm talking about. I'll come back to this again and illustrate the relationship here. All right, so I've already said that in terms of our in this case is mine and Gus Demori's suggestions, we're telling people if you've got a reason for doing a 24-2, then there should be a reason for doing a 10-2 as well. And same thing with OCT, should have cube scans of the macular and disc both. All right, I'm going to add to that the following recommendations based on what I just showed you. You want to use probability maps here, not metrics. You don't want to decide whether eyes are normal or abnormal based on mean deviations or pattern deviations. You want to look at the actual probability maps as well. And same thing here. I seldom look at these pie charts, right? And I certainly wouldn't think of doing them without looking at the abnormal regions on the probability maps. Okay, so what you're looking for is damage that's accurate in nature, right? You're looking at something that has the appearance that it's glaucomatous damage. So everything should agree. And the advantage of this kind of report is to try to separate artifacts from real changes, because everything should agree. So let's take a look at this here. The damage here is actually throughout this whole region. You know, this eye started out something like this, and this whole region went down, right? There's the region that's associated with the macula, plus or minus 8 degrees. That's what this circle is here. That's what this circle is here, right? The damage here actually looks something like this. So you've got damage in this region here, which is this region here. So you've got this whole arcuate region affected, which is impinging on the macula. That's why you see this. And it's showing up here on the 10-2 and here in the 24-2. This is the picture you want. This is how you want to understand glaucoma, not based on pie charts or pattern standard deviations or whatever. So that this region right here is the same as that region there, is the same as this region here, and actually is the same as this region right there. All right. We're actually working on, this is a perspective that just came out in Journal of Glaucoma, and we're actually working on making these relationships within this report easier to see, and with the hopes that it'll eventually at least get into the Topcon machines and Heidelberg machines, the two companies we're working with. So here's our version of a Topcon report for wide field, which I'll tell you about in a second. But what we're going to do eventually is use a model, probably the Jansonius model. So in this particular case, you have this field here and you have these points here, but what's going on? So this is what our software allows us to do, and which we hope eventually commercial reports will allow you to do. You can put a marker on here and you say, well, this sort of looks abnormal. Where should I see abnormalities? Well, it would then predict the region of here that's associated with this, and the region down here and here that's associated with that. Is that clear? So here's our prototype that we're working on for a report that would be based on the Topcon. Here's a report that would be based on the Heidelberg. I can come back to that later. All right, so where can I find these reports on my machine? This is the best report to use. And I'm going to deal with 3 machines, Topcon, Zeiss, and Heidelberg. So here's, the Topcon is now easy because as of relatively recently, the this here is to remind you that I have a financial relationship with Topcon. I have grants and equipment. I get no money if you use this report or if you buy equipment, but I do have a financial relationship. Anyhow, back to this. This report's based on our lab report and a single wide field 12 by 9 OCT report. It's available in the Maestro instruments, for the Maestro instruments, and for Topcon and for Triton instruments outside of USA. Okay, so let me just tell you about the report. It's basically a lab report with a few extras. All right, so it's based on one scan protocol. The scan is 9 by 12. It includes both the disc and the macula. If you have a Triton, it has 256 line scans. If you've got a Maestro, it's got 128. They all have 512A scans, 9 by 12. That's what a B scan looks like. That's the retinal nerve fiber layer. That's the retinal ganglion cell plus layer. And from this one scan, we get this report. This circle scan up here is not a true circle scan. It's a derived circle scan, right? So it's not as pretty as something that's averaged a lot, but it still has very good resolution, right? So this is what the report looks like. This is an end-stin, meaning that the temporal half of the retina is in the middle. Let me just blow this up. So that's an end-stin plot. These, to remind you, these are the thickness and probability maps for the ganglion cell. This is thickness, that's field. This is retina view, that's field view. It's just the same as our lab report. You can see this piece missing from this eye here. is, there it is on the probability map. Here it is over here, right? I guess that would be over here. And most importantly, there it is. You can see it on the image. So Murray asked before, do I look at the image? Yes, I look at the image. He also asked, do I need the image? No, I don't need the image because there it is right here. I can see it here. I can see it there. And I can see it here. I know this is real. Here's another eye, right? So let's blow this up just to take a look at it. It's a defect that's very close to fixation. And there it is on the ganglion cell. So that's retinal nerve fiber. That's ganglion cell. Here's the 24-2. This is sort of interesting. It's a right eye. So you've got one deep point right there. If you only had that, what do you think? What do you think? You don't think glaucoma. You think, is that a big optic disc, or is that a retinal disease? You know, I mean, what is going on? Let's blow it up, right? Well, that point there is this point right here. And here it is there. You know, so you're actually seeing a part of this arcuate defect that's secondary to glaucoma. Here's the 10-2. If we circle those points, you can see the agreement here and the agreement there. All right, Heidelberg also has a report based on our work that's just come out. This is the US version. And this is a version that's available outside the US. They don't have approval for the probability maps here yet. So this is a thickness map. And then instead of a probability map, this is the thickness map in field view with the visual field points superimposed. So you can do most of the same things, but you just don't have the probability map. And again, I've got a financial relationship with Heidelberg. All right, so retinal nerve fiber layer thickness, just to review, ganglion cell thickness, and this missing piece here corresponds to this location, corresponds to this location, and there it is on the image. You're done in seconds. You know exactly what's happening. This whole region is abnormal in this eye, and it's particularly affecting, or it's also affecting close to fixation. And then this is the probability map, again, not available in the US version, and the ganglion cell probability map. They do something a little different. They also code significantly thicker, which confuses some people, but on the other hand, it's got some advantages too. All right, so how do you deal with this? So this is upper visual field, inferior retina. So here's, you know, you can just take this and circle it. And if you had the US version, you would have the thickness map that you would just circle the abnormal region. And there's the 10-2. Okay, this is actually a defect like this here. All right, Zeiss. Those of you using Zeiss, if you only look at this report, you're only getting half the information, right? It does not include a macula retinal a ganglion cell scan, right? So you want to look at the report for the macula as well, which I don't show here, because actually I like this even better. So this is their panel map. This is the map that's closest to our report. And let me just tell you something about it. So it's based on 2 cube scans. By the way, this is not this patient's eye. I just used this fundus photo just for an example. I just want to illustrate that 1 cube scan is centered on the disc and 1 cube scan is centered on the macula, just like we were showing for our lab report. All right. This is retinal nerve fiber layer thickness, just like in our report. All right. This is a probability map. They call it a deviation map. And there, if I'm not mistaken, these colors are not continuous. Red is 1%, yellow is 5%, that's it. And then the rest is not significant. What's a little unusual about this, and again, there's some advantages and disadvantages, is that this is the deviation map for the retinal nerve fiber layer, and this is the deviation map for the retinal ganglion cell layer. And then this is a thickness map in T-SNP, although I believe that they now have a toggle that you can actually look at that in instant too. I'll mention that later. I find this totally useless. I would much prefer if they replace that with a fundus, with a one of these images. You know, much prefer if they blew this up, made this a little prettier, which they could do with some averaging, and put this here instead. It'd be much more valuable than those pie charts, in my opinion. Okay, so compared to our report, you know, this is the same as that. This is the same as that. This part here is the same as this. And this part here is the same as this, except this is not, these are not in field view. Okay. You can take this here, right? You know, you always, so my comment here is always look, you know, always look at this. Right? This actually speaks to one of the questions that I was asked about why you see things better in some places versus others, since the damage all starts in the optic disc. Well, you know, this was the average data I showed you in the first talk. Look how similar this patient is to the average data. You have a defect that goes from here to here, that's including all of this region here, but it's showing up a little better here on the ganglion cells and showing up a little better here on the retinal nerve fiber layer. But it's all one defect. So you could actually say, well, in this section here, it's showing up sooner on ganglion cells, and over here it's showing up sooner on retinal nerve fiber layer, but it's all one defect. And it's occurring at the same time. It's only a matter of where it's easy to see. All right. You can also compare this to visual fields. In the beginning, you could try this exercise, but you'll get pretty good at doing this without what I'm about to show you. We can flip this into field view, and we can superimpose these points onto it. You can take a screen capture. You can go to my website and look at some of the lectures, or I can send this to you if you need it. But, right. So here's an example. Here's an eye. Now, sometimes total deviation matches better, sometimes pattern deviation. It really depends on what the cause is. In this particular case, there's a cataract, so you don't believe this. You have this one deep point here, right? That's this point right there, right? If you look at the pattern deviation of the 10-2 instead, now you've got perfect agreement. Agreement won't always be perfect. Sometimes it'll be shifted one way or the other because there's some anatomical variation among us, but nevertheless, this is the kind of agreement you can get. All right. So the problem is that the commonly used 24-2s and 10-2 disc scans miss or underestimate central damage. You want to make sure you look at these probability maps. The last point I want to make about what you should be doing is you want to inspect scan images, at least this image. And in some cases, you'll want to look at other B scan images too. Right. And actually, if you go back to, here are two review articles that Gus and I wrote in 2018 that summarizes our modifications of what we call the common clinical paradigm. So this is what we were telling clinicians to do then, right? Now we're going one step further. So here's one of the updates that Murray referred to. If the workflow allows you to do it, we recommend you do an OCT first. So you do an OCT first like this. You look closely at the scan image to make sure segmentation is good and nothing else is going on. Sometimes you can actually see where the damage is, right? You look closely at the thickness and probability maps. So if you had this eye, you'd say, oh, wow, something's close to fixation. And then you decide on a 24 or 10-2. In this case, you would do a 10-2 first because you're really worried about this. And once you did that, you'd see, well, that's what you're going to follow this eye with. You may want to occasionally do a 24-2 to see if anything is happening out here, but certainly this is what you're worried about at the moment. All right. So let me now give you some examples of, and we'll also talk about some artifacts. What we are, something that Gus as a clinician always reminds me to remind clinicians of is we're not only claiming you can be more accurate with the kind of approach we're pushing, we're also claiming you can be faster because we know you're under time pressure at the moment, always under time pressure. Take that back. All right. In many cases, it's clear right from the start that you got an abnormal eye, and you can quickly understand because of agreement within the reports, the nature of the damage. So I'm going to show you in all these examples, I'm going to show you the PanoMap from Zeiss, along with our version of the Heidelberg map and our version of the Topcon map, right? So we can blow these things up, right? And you can see the agreement. These two are in field view. This isn't. So let's flip this to a field view. You can see the agreement here is pretty good. In fact, if you take this here and, whoops, if you take this here and put it up here, this should match this, which it does. I want to make a point here because I think this came up in when we were talking once before, Murray, to a group, something like this. I'm going to call it the cookie cutter effect. What Zeiss is actually doing is masking out everything outside. I think it's plus or minus 8 degrees. So everything outside of this gets masked out because it becomes variable. So this here gets masked out, you know, which is fine for some purposes. You just have to be careful because it will take something that's an artifact and make it look like a arcuate. All right. So here's the visual fields for these eyes, right? So this damage here is here, here, and here. Damage on the 24-2 here is here, here, and here. You can see the agreement. There's also something subtly perhaps going on in the inferior, and you can see some subtle, you can see that would be here. All right, just like many eyes that you're dealing with are abnormal, and you can quickly understand them, there are many eyes that you're going to be dealing with that are normal, and those also can be even more quickly dealt with. So you get an eye like this, you can take any one of these reports and this looks good, this looks good, this looks good, you're done, right? So the fact that you can be fast with eyes that are clearly normal and clearly abnormal means you can spend more time agonizing about the ones that aren't so easy, and there are many of those. Here's another eye, you know, it takes me 3-4 seconds to say, this is really healthy looking, this all looks good, this all looks good. It doesn't make any difference which of these reports I'm looking at, I come to the same conclusion. And yet another eye. In this particular case here, I think this probably is a case like you were talking about. This could be an older person. This looks artifactual to me because this is the retinal nerve fibrillate is normal. It's not arcuate in shape, and I'm going to discount that. I may take a close look at 10-2 because of this, but nevertheless. And here's what the probability maps look like. Again, cookie cutter effect. Okay, here's another example. There are a couple of things here to point out. One is, you know, this is clearly an artifact, and you can see it up here. This is an eye that's thicker than normal. You know, so this plot looks different than the other companies because they're showing significance for thicker than normal, not just thinner. And here's another one. Again, these are all normal. I'm not going to get concerned about this one. This looks so thick and healthy, and this looks so thick and healthy. All right, those are the easy ones. What about artifacts? I want to spend time on artifacts. The most difficult, I think the most difficult artifact to identify, because it's reasonably common, or one of the most difficult, I'll give you another one later, is so-called red disease due to blood vessel location. So here's an eye, and this is common in high myopes, for example. Here's an eye that if you just believe these pie charts, you'd say, oh, it's abnormal. And there it is, it's dipping into the red. And there it is, you know, nice big arcuate, it looks like, right? This is due to blood vessel location. And to understand this, you have to understand where the blood vessels are and why this creates a problem. So on this particular report, this red line shows the average location of the major temporal vein and arteries here and here. You can actually see where the location is based on where these peaks are, to tell you the truth. You notice that this red line is right in the center of the peak in the average controls. Okay, but anyhow, that's the average location for the blood vessel. This shadow here shows you where it is in this eye. So this eye has its vessel much more temporal, and because of that, for reasons I'll tell you in a moment, that's where the thick retinal nerve fiber is, and it creates this artifactual thinning. Same thing over here. All right. Now, the reason why this is true is because during development, these major veins and arteries develop together with the axons from the ganglion cells, so that in most eyes, the thickest region of retinal nerve fiber layer is also in the region where these vessels are. So I'll just make this shallow. So this, you can see retinal nerve fiber layer thickness, follows these vessels. Same thing is true in a myope. Here's the fundus view for this myope. You can see the vessels are much more temporal. That's due to development. It's not an optical effect. Here's the thickness map. Let's make it thinner. So you can see in the myope also, the thickest part of the retinal nerve fiber layer, it goes along with the vessels, but now this gets displaced and creates these artificial or artifactual defects. Here's another healthy control. This is not a high myope, by the way, so it doesn't have to be a high myope to have this. You look at this and you say, oh my goodness, that looks like an arcuate, right? But if you look at, this is where the vessels should be, and the vessels are actually over here someplace where this peak is. So this is shifted and it's creating this artifact there. So you want to take a look at the vessel location. All right, so here's a suspect without glaucoma, right? Let's blow up the probability maps here, and you can see this, and this all looks like an arcuate. It's all due to blood vessel location. So there's the actual location of the vessels, and because it's shifted over a little bit, you're getting this artifactual dip. This becomes really tricky now when you combine a change in blood vessel location with glaucoma. So there's a patient with early glaucoma, and now the blood vessel location is going to complicate interpretation. So how do you know? All right, so in this case here, you can see this eye here, the vessels aren't displaced all that much, but yet you've got a defect here. So this is real, and you can see it there, here. Right. Over here, on the other hand, this is more complicated because this now is shifted over, right? So is this real or is this due to blood vessel location, right? Well, first of all, this is clearly real because you want everything, remember, everything should agree. So I look at this and now I look down here and I say, oh, well, that's clearly abnormal because look, the ganglion cells are missing too. And there it is, you can see the defect here, right? But there's a defect up here too. So this is probably also real. And this gets confirmed with the visual fields. So you can take those visual fields and we can put them all in field view and put the 10-2 on top and 24-2, and you can see that you're going to get agreement and you've got damage in both. So you figure this out based on the OCT actually, but the visual fields confirm it. Central artifacts. You see something like this, it's almost always an artifact. If you see a partial circle around fixation, it's almost always an artifact. And here's a paper that Gus is first author on, in which we looked at these in some detail. This is very common, and it's due to anatomical variation in circumfoveal thickness of the ganglion cells. Right? So for example, here's an eye. You notice that all of these probability plots have circles or partial circles, right? Almost always an artifact. Right? So the advice is, if you have an abnormal region that's circular and close to fixations, it's almost certainly not due to glaucomatous damage, but you want to check the consistency with the rest of the report. All right, what about this? What's going on here? So this gets into the difficult category I mentioned before of picking up macula damage. You know, I'm worried about this eye because not only do I see something here, but I see something here and here. So it's not like a segmentation error, because sometimes sometimes the segmentation may cheat the ganglion cells and give it to the retinal nerve fiber. These are both down in the same place. That certainly looks real to me, but I want to see confirmation. So here's the 3 reports. This has some kind of an artifact in it, so I dismissed that. And I would, if I was just using this machine, this person wouldn't have to be rescanned. Here, you know, these are both saying the same thing. So let's just blow this one up. So you can see that this is borderline and it's down here and here. You know, that's real. I don't know if it's glaucoma, but that's real. Same thing. This is actually in the red here and here, right? So what about the 10-2? You certainly want to see a 10-2, you know, so if I see these 2, if I also have a 10-2 that agrees, then I'm sure I have optic neuropathy. Well, the 10-2, I've got 2 of them here within weeks of the OCT scan. And then here's one 6 months later. It includes this region, right? But it includes other regions too. So something is going on here. I think it's probably real, but I have no idea if it's glaucoma. You look at the fundus exam, I'm not an expert on this, so I'm not going to try to overinterpret this, but this looks pale to me here, you know. And this is 6 months later. This is a year later. This is a year and a half later. It's not changing much. So I think there's some kind of an optic neuropathy in this particular eye. I don't think it's glaucoma, but it could be. Actually, the experts in New York disagreed about this also. All right, segmentation errors. That's one reason to look at scan images. You know, so you want to take a close look at least at this scan image here, at least at this scan image here. So I look at this here, and I say, oh, is that damaged? No, there's a segmentation error. Let's blow this up. You can see the segmentation error. Right, so I'm going to dismiss all of that, but I'm not going to dismiss this region here. So I have a whole lecture I could give you on segmentation errors and how it affects metrics and so on. Suffice it to say that all algorithms, all machines, all algorithms make mistakes, and your mistake is not looking at an image like this, because you can pick up, you can decide based on that whether you can trust the segmentation in these plots or not. Epiretinal membranes. You want to learn to identify epiretinal membranes. So I look at an eye like this, and I look at something like, whenever I see something funky like this, where it's thick, but it's got a weird pattern, right? It not only suggests epiretinal membranes to me, but after years of experience, it screams epiretinal membranes at me, right? And same here. This is just a weird looking pattern, weird looking patterns, probably epiretinal membranes. What you have to do in this case is go to the machine and look at the B scan through that. You look at the B scan through that, and there it is. Huh? So you want to learn to identify epiretinal membranes. This is an en face image on the TopCon report, which actually is really an outstanding way to pick up epiretinal membranes. You know, so if you put a line through here, you'll see this is an en face that's actually just averaging the top layer of right below what you're measuring as the inner limiting membrane. And so the pattern here, you know, all of this is epiretinal membrane. Anything that looks weird here, you can see the tension lines and so on. All right, does this eye have epiretinal membrane? Well, I look at this and I say, yes, epiretinal membrane. But here is the report from 3 different machines, right? Now, does it also have glaucoma? Now this is where you really earn your keep in terms of trying to interpret OCTs. So here's the visual field in these eyes. Here's the 10-2. Here are line scans through the center, B scans through the center, and a B scan in this direction here, right? And you can see the epiretinal membrane has pulled away the retinal nerve fiber layer here, right? So it's not clear to me whether this damage was done by glaucoma or whether that damage was done by the epiretinal membrane. So does this eye have glaucoma? It's not clear. What I would tell the expert at this point is you want to follow this eye because there's enough epiretinal membrane damage here to explain visual fields. An epiretinal membrane by itself will not necessarily increase threshold. They don't reflect or block that much light. However, they can cause damage, like I think is happening in this case, that can give you field defects. Oh, and this is what here's a disc that I think experts will debate as to whether it's normal or abnormal. All right, the last item on this list is the lower end of normal. Somebody's got to be at the lower end of normal. Remember, yellow is 5% here. So you're going to have eyes that are going to be, jiggle around here, the yellow region, because they're just at the lower end of normal. And they won't necessarily have ganglion cells that are down, but they might, right? So you're going to see a lot of red here, and you may or may not see red there, or vice versa, right? So all of this is down, right? So how do you tell? Well, you need visual fields in these cases, but here's one thing you can do that will get you part of the way, or largely a large part of the way there. So here's a healthy control with a global thickness of 66, well into the abnormal range. Here's a glaucoma patient with the same global average. What tends to happen in these two cases is the glaucoma patient, you will see vessels sticking up here in your image. Whereas here, the vessels don't stick up. This is not foolproof. You can get glaucoma patients that look like this and vice versa. But this, in general, is the picture. Right? So, for example, here's widespread damage. Is this widespread damage or lower end of normal? Or some mixture? Right? Well, it's hard to tell from that. Hard to tell from that. But they're all showing the same thing, by the way. Right? So if you take a close look at a good image scan, this is abnormal. There's no question in my mind it's abnormal. You can actually see this being pulled up. So this whole region at least is abnormal, probably this region here too, right? Same thing on the top con, abnormal, abnormal, abnormal. And here's the 24-dash. So now I do 20. So I'm already saying this eye has glaucoma without doing a 24-2. You do 24-2, and these regions here are associated with those regions there topographically. Okay, so if we remove these, and you can see the agreement. I just want to say, a pause at this point. I'm almost done with this part of the talk. I just want to pause at this point to say that all these examples that I've been presenting come from a database that my friend and colleague, Gus Demores, has been working on for a number of years at Columbia Medical. And the patients are patients referred by Jeff Liebman, Dana Blumberg, and Lama Alswad, and Jack Chaffee. All right, so I want to say a little something about the topics not covered. So things I could have added if Murray made me lecture for another 5 hours is OCT can be used in most eyes with high myopia, contrary to popular belief. It can be used in many eyes with advanced glaucoma, also contrary to popular belief. It can be used to pick up disease masquerading as glaucoma if you look at the B scans through the macula. And it can be, and damage to the macula can be diffuse as well as subtle. So these are things not covered. Some of those are covered by lectures in my website, and this will get you there. Mari, I think, is it okay with you? I think it probably will be, so I'm just going to assume it is at this point to just give a couple more minutes about coming attractions.
Sure.
Okay, and then we'll do discussion. So here's something that Topcon just came out with, which we're working on with, and it's available Maestro and Triton through Harmony in Canada at the moment, and also Central and South America. It's not available in the US as of now, and it may be probably some modified version. But it's basically our report, but interactive. Like it or not, now I'm speaking to the older folks, you're going to be going to the machine, or you're going to be going to your computer at least to interpret scans. You're not going to be getting pieces of paper, and you wouldn't even, and I guarantee you, when you see what this can do, you won't want the pieces of paper. You're going to want, or even if it's a PDF, you're going to want the interactive. So here's an interactive program that's our report that has the elements of our report here that you've just seen, plus a fundus photo, which this will be a real fundus photo. And then it's got the 24-2 information too. So let's blow this up. So you can toggle on this here between total deviation and pattern deviation, and this changes. You can toggle between 10-2 and 24-2, and this changes. And it also changes where these points are filled in terms of color, right? This is for progression. Now you can compare time 1 with time 2, and you can do it, visually, or you can do it using a technique we described in this paper here, where if these are lined up correctly enough, you can toggle between 2 days, the same way the old timers in the audience toggle between fundus photos, and you can see if everything agrees. This should be changing, that should be changing, that should be changing at the same time. In this here, if you click on this, it will toggle between the 2 different days that you want. So again, the challenge is to get these lined up correctly, but it's a way to look at progression. And then this is a side-by-side comparison of 2 times. So you can ask, well, that sort of looks like it might get a little bigger, but not much. Oh, but that's getting a little bigger, that's getting bigger, and that's changing. Well, I've got progression. And then this is the same thing for the 24-2. The other thing it allows you to do, you have something like this, and you want to know what's going on here. Let's say, is this real or not? Well, you can click this and then scan through your B-scan. So right now you can do a lot of this on your machine, not all this on your machine, but where the software is heading, I believe in all companies, I'm just giving you one example, is going to be on an interactive way where you can make sure that everything is agreeing. It's not going to be, asking whether the pattern deviation is abnormal here and the pie chart is abnormal someplace that's equivalent. Oh, so this is what you would see, and you'll be able to see the segmentation. Thank you. I'm ready for questions, Murray.
Great. Okay, so we got a bunch of really great questions. First question, how does visual fields and OCT define horizontal meridian to overlay them together? Fovea, center of the disc, visual horizontal, raphe.
How does it define which, did you say?
How does the visual, each define horizontal meridian?
Oh yeah, also a great question.
Good question. Because
Yeah, it's something I've done a lot of thinking about. So it starts out by what you think is variability. Let me back up. A fundamental difference between the philosophy of scanning in the Heidelberg versus everybody else is they scan along the axis between the center of the fovea and the center of the disc. The logic there is that will decrease variability. And there are 2 kinds of variability that you want to think about. One kind has to do with head torsion and eye torsion. And if I come in one day and I tilt my head a little bit compared to the day before, and this happens much more than I thought a couple of years ago, then everything gets tilted And if I adjust by the foveal to disc angle, I will correct that 100%. If you and I have different anatomies and we have different foveal to disc centers, that may also correct some of that, but it won't correct all of it, right? So what we're doing with the TopCon report now is after the scan, we're tilting it, everybody along the same foveal to disc center, and because we've learned we've gotten rid of a lot of variability. That's because there's much more torsion involved than we thought, and because it gets rid of some of the variability due to anatomical differences. Now, here's where the Rafe comes in. When you adjust different individuals, we showed in our 2013 review paper, we showed that if you adjust everybody by the fovea to disc angle, you will bring the retinal nerve fiber into agreement, but you'll throw the Rafe out of whack. Because if it's an anatomical variation as opposed to a eye rotation, the Rafe doesn't vary amongst us as much as the fovea angle does. So that's the background. So what we do is we adjust for foveal disc angle because it gets rid of the torsion, right? And we put the fields on top of it. But probably what you should do is when you do the macular is you don't rotate the macula, because the Rafe at the macula doesn't change as much. So now the good news is these are not huge differences. You know, they're really not big differences at all, especially when you consider when people are doing visual fields, they're also tilting their eye a little bit, you know. And the Rafe is not equivalent with the meridian anyway, you know, so you'll more likely see a nasal step that dribbles below the horizontal meridian rather than above, because the meridian is actually slanted a little bit. So Murray, you can decide if that's
Great.
That's probably more than the person asking the question wanted.
No, that's a great question. We've talked about that before. Okay, another on macular evaluation.
The bottom line is we're centering the fovea, we're centering the disc, and we're adjusting for foveal disc angle, you know, and that still leaves some variability, but that, you know, it's good enough for clinical use.
Right. On macular evaluation, what are your thoughts on evaluating the GCL and IPL together versus just the GCL as available on the Spectralis? Is there, you know, is error more inherent in either?
Yeah, so I think it's pretty clear that there's less variability when you combine them, because one of the most difficult borders to pick up is the IPL ganglion cell layer border. And in fact, any software that tries to do it outside the macula is just guessing, because outside the macula, that's only the ganglion cells are only a single layer thick if you look at the histology. So my own belief is that, except for perhaps some research questions, you're better off having them combined. There's going to be less variability. And what we're actually looking at,
I think it's the OptiView that just uses one, or just uses the RNFL, not the GCL, or isn't it?
no, well, I don't know about the OptiView, but the Zeiss and TopCon both combine them.
Combine them,
You know,
right?
they just report, yeah, combine it. And Heidelberg has them separate. You
Right.
can look at one versus or the other separately, and I think probably there's probably less variability if you just combine the two of them together.
Okay.
For research purposes, you know, it creates some interest. We're actually doing a paper for probably next year's ARVO where we're looking at change in the IPL over time versus change in the ganglion cell over time, to see if there's any extra information in it. I doubt whether there's going to be.
Okay, so there is a question here on a recommendation for which field to run first, 10-2 or the 24-2, but you've already addressed that, saying that look at the OCT first.
You look at the OCT first. If your workflow, the other thing we tell clinicians is if your workflow is such that you can't do, for whatever reason, the OCT first, then what we tell people is almost anything should buy you a 10-2 of the following. If you can't correct the acuity to 20/20, or if the patient has these vague complaints about light and dark or glare or anything at all like that, do the 10-2 first. We work, Bob Rich, for example, often does the 10-2 first on normal tension because the macular damage is so common in normal tension.
Right. So, you already, discussed to a certain extent just progression analysis and the implications with your Hood report. The question, is, what about variability when you're simply looking at two? And is it the fact that you're actually looking at the B scans where that variability is reduced, or is it or do you need a certain amount of change to actually see those changes in the B scan?
Yes, so the main focus of our research the last 2 or 3 years has been progression, and we're progressing very slowly, but we're making progress. We don't have a complete. We don't have an optimal way yet of doing this quantitatively, although we're working on it using the kind of model I showed with Jansonius. So you have equivalent regions, and we've got some things we're working on there. But the simple answer at the moment is, if I'm using a TopCon machine, then I'll look at the B scan, but I'm really interested in whether the probability maps all agree. Whether the ganglion cell is changing, the retinal nerve fiber layer is changing, and the retinal and the thickness plots are changing in the same place, right? And I don't have a quantitative way, although we've played with, and we're still playing with, regions of interest where you can circle those regions you're interested in and ask whether they agree and whether they differ greater than normal variability. If I'm using a Heidelberg, for progression, the fact that they can put the images back in the same place and that the resolution of those images is so good because it's a real circle scan, we'll call progression simply based on the circle scans, the way a radiologist would judge a tumor in the brain. That is, we look at the abnormal region and we look at the change, and then if you've got fields, you can ask whether it's similar. But we don't have these old, these are clinical. This is what we're doing clinically, and then research-wise, we're trying to turn those techniques into quantitative techniques, eventually to go back into the clinic. Did that answer the question, Murray?
Yeah, it does. But my guess is that you need quite a bit of change to be able to see them visually, even with high resolution. Is that correct?
It's a lot. And let me put it this way: we can call progression reliably in situations where the metrics changes that have been, the various metric methods, rule of 5 and things like that, screw up. We've got a couple of papers about to come out, I hope, that make similar points, that if anybody who believes they can use global thickness for progression, better be looking at those scans, because once they look at the scans, they're going to be very suspicious. They should only be using those metrics if they look at the scans, because small segmentation errors can give you a global thickness change of 2 microns, 3 microns, 4 microns.
Right. Okay. So here's a question, and this is something that we've discussed ad infinitum. And it has to do with the pie charts or the clock hour charts. We both discussed, and we both have been at meetings with Zeiss trying to convince them to get rid of them just because of the misleading. But the question is, you state that the pie charts aren't too helpful for you. Are you talking about diagnosis, not management?
Well, I'm certainly, certainly, I would not manage based on them. That's for damn sure. For diagnosis, if I was forced to use one, as a quick screen that I then would want to follow up other things with, the quadrants probably do better than any of of all the metrics. Visual field pattern, standard deviation, mean deviation, all the metrics. The best is probably the quadrant one. but I would not use that by itself. You'll miss important damage, and
You miss local
it's
change.
not necessary. Once you have reports that have all this information in it, you can be just as quick as looking at a pie chart, and you'll be much more accurate.
Right. There's a question here in stereo photos. Are they necessary? And why don't we hold that, because Peter Lally is going to be getting into that in the last hour. I think Peter would be a lot more versed to talk about that, if that's okay. So can these instruments, you talked about harmony in your report and having a visual field data in there. Can these instruments incorporate visual field data from various instruments, including the octopus?
In principle, yes. In practice, none of them are, in practice, they're not doing it yet. We're just starting to do it. Right. Even with just you're going to see it with the Zeiss data first, but only Zeiss has access, to the, how do I want to put this?
Right, it's proprietary data.
Anybody other than Zeiss that's pulling out visual field information and starting to present it in a way that it can be compared, and that's just beginning. They'll be able to do it with other machines too.
Right.
That's the way that's what I wanted to say.
Yeah. I mean, there is some software from years ago out of Germany that did somehow get, by going backwards, get some access to of what the Zeiss data is, but for the most part, the Zeiss field data stays within Zeiss.
Yeah, but there are other ways to get it that these other companies are using, and and there's no reason why they wouldn't be able to do it for other machines too. But.
Right. So here's you touched on detecting progression. Is it important to perform multiple scans of the same cube at the same day when we compare scans from different years?
Is it important to do what?
Take multiple scans of the same cube on the same day.
Oh, yeah, that's a great question too, actually. It doesn't, if you're talking about, if you're talking about the Heidelberg, that protocol takes a while, and it's, I can understand only doing that once. If you're talking about a Zeiss or a Topcon, it doesn't take that long. The person's there. Hit the button again and get a repeat. Don't you, Murray? Do you get repeats?
For the Cirrus, no, I don't.
Yeah, it's not that hard. The answer is I would get a repeat. I would certainly get a repeat if the tech had any concern that they didn't get a decent scan,
Right.
But time them. It doesn't take that much extra time.
No, it's a good point. Here's a comment. The OptiView GCC uses the nerve fiber layer, the GCL, and the IPL together, not just
Right.
the GCL. Good.
Right.
Yeah.
So what about it?
That the OptiView uses the three layers, incorporates the IPL, GCL, as well as the RNFL.
Yeah, that's their GCC.
Right. Yeah.
Right.
And then how do you utilize OCT in advanced glaucoma given the floor effect? So we have a minute or two.
Yeah, that's a great question. Take a look at our recent publications, but here's a simple answer. We're partially responsible, along with Ted Gower-Heath and a few others, for the so-called floor effect. And we were all looking at, like either global statistics or regions. And the rule that we've came up with is if an area has a mean deviation of more than -10, you're in the noise. Well, here's the key. That rule applies to individual points. So what this means is if you have any point on your 10-2 or 24-2 that is better than about -8, on average, you will have some tissue remaining. So these eyes that globally are in the floor are so-called floor effect, globally are 30 microns, 40 microns. They often have a little remaining 10-2, right? There is tissue there on your circle scan that you can follow the same way a radiologist would follow a tumor. And that's what we're doing in practice. You know, we are with the patients we're following a lot of Bob Rich's advanced glaucoma patients, and we're looking at circle scans and asking whether the little bit of tissue remaining that's associated with that little piece of the 10-2 remaining is getting worse or not. So it's just not true that you can't use it in advanced glaucoma. Now once the 10-2 and 24-2 are below about -10, then you're in a real floor effect.
Right. Last question. Dilated versus non-dilated images, does this affect analysis significantly?
There's a literature on this, and the answer is no. I wouldn't mix the two. We don't dilate, you know. Now, unless you've got a really small pupil. So the secret here is not dilating or not, or it's whether you've got decent contrast. So if you have a patient with a very small pupil and the contrast is terrible, the contrast affects the accuracy of the segmentation. But you don't need to dilate in most cases.
Okay, great. Don, thank you very much. This was great. You just did a phenomenal job as usual. Thank you, Don, and let me turn it back over to Mike.
Okay, thank you, Mary, for inviting me.
Thanks, Don. Great stuff.
Thank you, Don. Once again, you've exceeded our expectations, and we so appreciate you being able to spend time with the educators group and the rest of the OGS. Thank you so very much.
I have to say, it's really weird talking to just a computer screen.
You know what? It went superbly. I mean, your presentations and your slides and the details that you put into those slides and show step by step. I mean, it's perfect for this virtual environment. So, I think we all feel better being at home right now, and it was just wonderful. Great questions and interactions. So far, this is just exceeding my expectations. So thank you again.
Yeah. Well, you can see I'm all for remote. I don't even get my hair cut.
Exactly. It's just it's perfect. Just
Okay.
a couple of quick notes before we take our 30-minute break here. One is I want to remind everyone that if I can share my screen here. Kelly, you have to allow me to share my screen. Let's see if I can do that. I want to remind everyone where some of the references and resources are to go for Don's information and everyone else's information who is presenting stuff today. Good. One more second here. And so, yes, no, that's not it. Well, looks like I lost it.
So, Mike,
I lost everything. I lost everything here.
Well, Kelly did email out 2 pages that were the suggested readings, if that's what you're looking for.
And one last thing, actually, I see, maybe I can get it. The one last thing is I wanted to thank our sponsors, because we had a lot of sponsors here. Maybe I can't get their slide up, but let me just mention them by name. The sponsors, very important to putting on this production. We really thank their support. Many of them have been with us at our past live meetings and our educators meeting. I would like to extend thanks to Aerie Pharmaceuticals, Allergan, Bausch & Lomb, Heidelberg Engineering, Ivantis, and Sun Ophthalmics. Apologies for these technical difficulties right here. Let's all take a 30-minute break, and we'll be back with Tom Freddo and his presentation on the anterior segment.
Right. We'll start at 12:30, and perhaps Kelly can put up the sponsor page for the break.
Yep.
Thank you. 12:30.
On my end. Thanks, everybody.